what I did in its place is just put a talk that I gave at IMAS recently on autograft infusion technique. And this is something that I think at least our fellows at least have heard me talk about. And I don't think I've shared the slides yet with any of you guys, but it's been something I've wanted to talk about. So probably the most important disclosure here is that C-Spine, while I don't receive any royalty for this product, this talk at IMS was sponsored by C-Spine. So there is that. I think that's important to make note of. All right, so historically, we think of graft material as osteoinductive, osteogenic, or osteoconductive, and we think of iliac crest sort of being that sweet spot between all of them, because it can both be structural. It's got some osteogenic factors in it. It's inductive because it's got the right scaffold. And the right cells. But I think the bigger question that we have had is, does autograft work, and do we know why? So if we look at published literature on this topic, the iliac crest fusion rate in the posterolateral space for posterolateral fusions ranges somewhere between 60 and 90%. And if you wanted to average it out, it comes 75 to sort of a good rule of thumb. And it is technique dependent, right? I mean, it depends also if you're using interbodies, if you're instrumenting the spine, if the graft bed has been prepared in a good way, or if it was done sloppily. All those things will have a very profound impact in making the substrate of the graft, either effective or even potentially useless, despite it being the graft material. So when we look at sort of modern spine surgery, it's pretty uncommon for us to be harvesting iliac crest anymore. And the majority of spine surgeons, when they're working with any type of graft material, we're almost always now going towards local bone, and then whatever supplemental bone graft that we then decide to use as surgeons. And so if we look at local bone versus autogenous iliac crest, there are some studies that look at this as well. And iliac crest seems to outperform local bone by a bit. In a local single level model, it does seem to be some equivalence, but in multi-level model, the iliac crest far outweighs the local bone. So with a one level, it seems to be okay. With multi-level, not as okay. So for those of you who've operated with me, you kind of have an idea of, in the open setting at least, how I like to get the fusion to be performed. But just to say, like how I do things, just because this is, I think, one of those topics where how I do this actually matters a lot, because the technique itself may be as, if not more important than the bone graft material. So, and one of the comments I make along this line is because, operating overseas, we're operating with surgeons that don't have availability of bone graft material. So, in other words, they don't have BMPs, and they don't have the fancy, allogeneic bone grafting material, and yet they're somehow able to achieve fusions. And so I think the technique of fusion really matters. So I like to use the bone scalpel to take off the inferior facet. This usually exposes all the cartilage from the remaining superior articulating process, and the harvested IAP is then also used for bone grafting after you scrape off the cartilage off of the little section of bone that you remove. And then I usually allow the rest of the surgery to happen before I do any more bone graft harvest from locally. And with the exception of if you have to do osteotomy, sometimes you need to remove the spinous processes. So that sometimes happens before that little straight line there. Then we'll remove the spinous process. where feasible, Cape gouges to delaminate the lamina. And then I usually use a very large burr, a 7mm cutting burr, to try to decorticate the inferior articulating process that's remaining. And then also, I like to have a really solid line of decorticated and bleeding bone from the inferior articulating process over the transverse process into the pars interarticularis, which then leads right back into the inferior articulating process of the level below. And so I like for that to kind of fall all the way along the entire spine posteriorly. If I'm really worried, then I'll also go into the posterolateral gutter with pars interarticularis to the transverse process and then pack bone posterolaterally as well. And so again, collecting all the bone is really important. And then for me, I like using the bone scalpel. So this is just kind of how just to show a video representation of what that looks like. A bone scalpel is used to take down that inferior articulating process. It's nice because it doesn't take all that much time to do. It is a little bit more time than if you just take an osteotome. But I've really come to enjoy this type of a device, whether you use, this isn't my Sonics, but there's other companies that make similar products. I think the point is well taken, which is instead of taking an osteotome towards the spinal canal, this now allows you to be a lot more accurate with your cuts and doesn't use very much force at all. And in a virgin spine, the chance of duotomy is excessively low. And if you're doing this for like laminectomies in a revision spine, I can see how that would be a potentially bigger problem. So, but yeah, so this happens all the way up and down, and you'll see that you get these nice cuts in the bone, and then when you remove them, it exposes the cartilaginous surface of the inferior articulating process, of the superior articulating. I think I've been saying it wrong the whole time. Of the superior articulating process. I'm sorry, guys. Of the SAP the entire time. And so having the cartilage exposed to the SAP now allows you to scrape all that off. And you do that with a curette, and you just scrape the cartilage off. You get rid of that stuff because it's not going to help you with fusion. And then you have a decent amount of bone from the IAPs that you took off that you can grind up for bone graft. So that's just to show you what I do. And then, looking at this model, you can see sort of where you would then make your connection with a burr from the superior articulating process over the SAP to the next superior articulating process. So, all right, a couple other things. Some of you see me like come in with like the Russians, or I think now we've renamed them Ukrainians. The little pickups that we use, the wide ones where we collect bone dust sometimes. And I think why maybe Dr. Eastlack yells when you suck out the bone dust. Well, there's some data that actually suggests that bone dust has osteogenic potential. And that's kind of why we want to harvest and save that. Even to the point where you want to irrigate before you decorticate at the end, because even all that dust is rich in osteogenic potential. And can be part of the milieu that you're trying to create for fusion. Its potential is a little bit less than that of bone chips, but mind you, it's still there. And so preparation again of that bone graft matters. So we sought out to see if cells mattered when we looked at this autograft viability. And so what we ended up trying to do is examine ILIAC CREST fusion rates with and without the cellular component of the CREST. And so we used a rabbit spinal fusion model that Bowden has published on previously. We used 16 bunnies, 8 as part of the control group, and then the test group was fully devitalized ILIAC CREST, and we did that by rinsing the CREST in saline and then freezing it and thawing it. So what we found was that well, sorry, we also did manual manipulation to test for fusion, as well as doing micro CTs. And if you want to see what we call the fusion, you would look at this on the left. This would be what we would call a fusion. On the right would be where the arthrodesis was not achieved. So if you look at fusion by manual palpation and micro CT, we in the control group, so the viable iliac crest group, we had a 58% fusion rate, but in the fully devitalized, we had none. So we then decided, well, what if we just partially devitalize it? And so what we did then in that sense was took the graft, rinsed it with saline, and then and did the fusion there. And what we ended up finding actually is that the fusion rate went up. Now we did lose one bunny in the group. We did not replace it. But this brought up an interesting point, which was, why is this sort of happening? Because we did find that there was a significant difference there. So it became interesting to us to figure out maybe it's something that we're doing on the back table. And so we ended up looking at is the bone cell viability over time. And what you see here is that the cellular viability decreases pretty rapidly on the back table. So where you go from cells being 100% viable at time 0, by the time you get to 2 hours out, only 38% of the cells are still viable. So why should we care about this? Well, what happens when you leave the bone on the back table for 90 minutes? And so again, taking these same animal model, we ended up harvesting iliac crest and put it on the back table. And then we re-implanted it after about 90 minutes of anesthesia. And if we left the iliac crest out to dry, so that we ended up doing is again same thing for this group, is we basically harvested the crest, but then instead of doing anything, all we did is put the crest in the back table. We left it out, and then we kept the bunnies under anesthesia for another hour and a half, and our fusion rate dropped to 0. And if we took the iliac crest that we harvested and actually just left it in saline before putting it back into the rabbit, we had a very high fusion rate. So, telling us something about the necessity of the environment with which you're leaving the bone graft on the back table. And again, we found some significance there. So I guess when it came down to like how this changed things for me, you realize that cells in the autograft actually do matter, because we were able to prove that. The bone cell viability, however, drops if you leave it out under dry conditions. And so what you have to be sure of is that you take care of the bone that you harvest, and you want to reduce the time that the bone's on the back table. And if you do have on the back table, you do want to keep it in saline, so that you at least maintain whatever viability is there. That's also why you want to limit how much bone you take early on. So even in my process where we take the inferior articulating process out, we do that in general, for a couple of reasons at that point of the case, but it's usually because you're trying to release the spine a bit to correct the deformity. And it seems to be the right cadence as you're trying to put your screws in freehand. So I think as far as timing of that part of it, you have the ability to see the anatomy a little bit clearer and have maybe a better shot at getting your freehand screws in the right orientation. So that's why I do it when I do it there. It may be that we keep moving further and further away from harvesting that bone towards the end for the very simple reason of this, but it does look like if you do harvest bone and you leave it over saline, you should be okay. So going back to that an early model that we saw, historically we think of things as genic, conductive, or inductive, and I think that's become a little bit more complex in 2022, where we realize those three elements are still really important, but there are other issues here at play, and it may be that cellular attachment or attraction matters, or that there's osteostimulation, and that the bioactivity of the implant that you're using, and the angiogenic potential of the graft that you use. So it appears that the simplistic model of these genic, inductive, and conductive is probably still really relevant, but there are likely other factors that do play into this. So this is a study we also did the osteoinduction of DBM. And so if you look at active DBM, when you just throw it into a muscle pouch, you'll see abundant bone formation. And if you take the BMPs out of that exact same group of DBMs, you'll find that you have absolutely no bone growth. So there is something to the fact that the inductivity has to go beyond just the structure, and that therefore, BMPs are osteoconductive. And if you look at even a ceramic with BMP, that's what that looks like. And you take the BMP away, it looks like a bunch of fibrous tissue. So bone is abundant with BMP and not without. So again, proof that BMPs should technically improve fusion rates. There's also some pretty significant costs associated with these different CBMs, so cellular bone matrices. They have a higher price than a regular DBM. So if you say, these are all products that say they have viable cell components. And if you look at what they cost in a hospital setting, they're always on a premium versus just a regular DBM. And you have to take into account that there will be some safety risks associated with this aseptic processing. And this actually became to light in last year when there was a batch of DBM there's a batch of DBM that ended up having TB in it, and they had to be removed from the market. But the question that we had internally is, okay, we know that cells matter in the autograft environment. Well, how about in the allogeneic environment? The ones that have these proposed viable cell components, do they matter there? And so we try to isolate the effect of these different CBMs, both with and without cells. And if the cells are effective, well, then the CBM should perform better than the ones without cells. And that would be a logical thought process. So we were able to garner some different DB or some different of these CBMs to put for our preclinical study. And we compared OsteoCell, Vivigen, and then OsteoStrand Plus. Now, OsteoStrand Plus does not have any cells, and it's just literally pure fibers on an Excel bone matrix. So it's 100% DBM fiber. So there's actually nothing that's part of this besides that. If you look at what we did here, as we took the DBM particles with cells that were dead and those that were alive, and then we compared them just to DBM fibers. And what we found was that when they were dead, we had 0% in osteocell, and when they were alive, we didn't have any either, interestingly enough. Now, Vivigen had the dead was 61% fusion rate, and live was 56%. And then, interestingly enough, if you just had 100% fiber-based DBM that had the highest fusion rates. So interestingly, that the OsteoCell Pro was the same with and without cells, and Vivigen was no statistical significance with and without cells either. So it appears that this idea that the cellular component of these products may not be that relevant. So that means there's something else that's causing this to happen. And if you look at the DBM component of these different products, OsteoCell Pro has only 25%. DBM in the Vivigen is about 45%, and OsteoStrand has 100%. So it may be that in this model, that fusion is driven more by the DBM and not the cells. So cells are important when they're the right cells, but I think you need to prepare your bone graft with care and pay a lot of attention to how you do things. And then I don't think all of these products are created equal. So I would just be careful when you're selecting your products that that you know the science behind it, because I think it matters. Not to say that it's, that there's one that's way superior than the other, but to say that just be cognizant of what you're putting in the patients, because I think it does matter. So, all right, that's what I got.
Thanks, Greg. And I think you underscored a lot of really important things that I think are sometimes overlooked in the training environment, and that is actually getting a fusion bed prepared. We had a talk this past Friday at UCSD, and it was aimed towards, minimally invasive deformity corrections and so forth. And it's the thing that we're always challenged with is it's not really just about placing instruments or manipulating the spine, but it's securing the fusion. And at the end of the day, we have to make sure that our methods of getting that accomplished are, reproducible. So I think, just the foundation of what, you spoke about is important. And then kind of rethinking, all of these products that we've been using for years. And I think we as scientist clinicians have to keep our eyes open and look for, ongoing ways to improve what we're doing so we can help our patients.
Yeah, great comment. Thanks, Don.
I couldn't agree more with Don's comment, because if you don't have a good bed and prepare it, no matter what you put there, it's not going to heal. And that was it.